It's my pleasure to welcome you all. I am Professor Mohamed Momtaz, Professor of Obstetrics and Gynecology at Cairo University. We will talk today about Doppler ultrasound in high-risk pregnancy, and this will be a presentation for about 30 minutes. Then we will take a break for about 5 minutes, and then we will do a hands-on demo. And this hands-on demo will be on a live case showing exactly how to take the Doppler measurements that we're going to explain to you during the presentation. The Doppler ultrasound in high-risk pregnancy is an important topic. It is used almost in all cases of high-risk pregnancy. The most important, of course, is the intrauterine restriction and placental insufficiency case. But we'll also mention other cases that Doppler can be used. As you can see here, it's never too late to learn. I have presented Doppler ultrasound many times, and in some instances, I find that doctors, especially who have been practicing obstetrics for a long time, or have been using a 2D ultrasound only for a long time, when you start to teach them how to do Doppler, they think that it is very difficult or impossible to learn, and that is too late for them to start learning about Doppler. Actually, it's never too late to learn, and Doppler is very easy. All ultrasound machines have now almost Doppler as a part of it. Even a little bit more advanced machines, we will have Doppler more or less incorporated in every probe, and usually even the measurements are taken as automatic measurements. To talk about Doppler, we have to talk about flow imaging modes, and flow imaging modes include spectral Doppler, color flow, power energy, amplitude flow. And spectral Doppler usually examines flow at one site, usually have detailed analysis and distribution of the flow. It has a good temporal or lateral resolution. It allows calculation of velocity and indices. On the other hand, the color flow usually gets an overview or an overall view of flow in an area or a region. It has limited flow information, and it has poor lateral resolution. It has direction information. As you can know, there is always color Doppler has more or less flow towards or away from the probe. Towards the probe, usually it is blue, but of course it can be changed to green or red or yellow, whatever color spectrum you're using. And the away from the probe is the opposite color. So if you're using blue for the towards, you will have red for the away, and vice versa. You can get velocity information, high or low, without real measurement, just from the intensity of the color. And you can get the turbulent flow, as you will see in the ductus venosus to detect the ductus venosus from the color, you will find turbulence. You will find many colors at the same point. The last or the third mode is the power or energy or amplitude flow. It is sensitive to low flow, and it has no directional information. Now there is a combination of color and power, which is directional color, but you can use, of course, power alone. It has very poor lateral resolution, and it is susceptible to noise. Usually it is used to detect very small vessels, and usually in static organs. Usually it is used in gynecology, used in detecting the spiral arterioles of the uterus, or detecting the perifollicular flow in the ovary. There is also two types of wave Doppler, the continuous wave and the pulse wave. The continuous wave use continuous transmission and reception of ultrasound, and the Doppler signals are obtained from all vessels in the path of the ultrasound beam. The continuous wave Doppler ultrasound is unable to determine the specific location of velocity within the beam and cannot be used to produce color flow images. But continuous wave Doppler is used in adult cardiac scans. Sometimes it is used also in fetal cardiology or fetal echocardiography to detect the more or less difference between, for example, the rate in the atria and the rate in the ventricle. You can see it clearly in a continuous wave spectrum analysis. Color flow is better called color mapping, and color mapping detects the flow of blood in fetal vessels. So color Doppler actually is not Doppler, it is color flow mapping. Why? Because color does not depend on the Doppler shift phenomena, does not measure the blood flow, does not measure the resistance, does not measure the ratio between the systolic and the diastolic flow. It only detects movement or motion. Sometimes even you can see color flow in areas where there is no blood flow. Just simply, for example, when the fetus is swallowing the amniotic fluid, if you put the box of color, you will see color in the mouth of the fetus, even sometime reaching the esophagus, due to the movement of amniotic fluid from the surrounding of the fetus to the mouth, to the nasopharynx, and to the esophagus. The direction of flow usually represented by different colors. As I said, you can use color in blue, you can use green and yellow, but at the end, you should put the spectrum that you're using. Of course, color Doppler is very important and indispensable in the diagnosis and assessment of something like congenital heart disease, because it will detect the chambers, the flow, the valves, the incompetence of the valves, if there is a VSD, or, I mean, it is essential, of course, in fetal echocardiography. Color flow can be used to identify vessels which require examination, can identify the direction of flow, can identify the presence of flow. It highlights if there is a gross circulation anomaly. For example, a vessel that is absent, renal artery that is not there. If you put the color box on the aorta and the supposed place of both renal arteries, and you find one is present, one is absent, and the kidney to the side is not present, so you know that this is congenital renal aplasia in this case. It provides beam vessel angle correction for velocity measurement. So when you see the vessel and you see the color flow and you want to put the spectrum or the pulse Doppler, you know exactly the angle that you want to use, because the angle usually is around 45 degrees to the flow of the blood inside the vessel. Whereas pulse wave Doppler is used to provide analysis of the flow at specific sites in the vessels under investigation, and we will discuss this in more details. When using color flow imaging with pulse wave Doppler, the combination between color flow and B-mode image is frozen while the pulse wave Doppler is activated, and this is called duplex ultrasound. Recently, some machines, or actually most machines, can use both color flow image and pulse wave Doppler in real time. So this is called triplex image scanning. The triplex mode, you will have live 2D and live Doppler, but this will decrease the quality of both because the machine resources will be exhausted somehow. So it's always better to detect the area you want to measure the flow, and then you fix the B mode or the 2D mode, and then use the duplex or the Doppler mode in a way to measure the flow. This is a much better way to do it. This is how better to use the duplex than the triplex. The power Doppler is a way to get the so-called amplitude information. You get flow from very small vessels, like here, for example, this is the peri-endometrial or the myometrial vessel supplying the endometrium, and here the perifollicular flow in the ovary. Usually very, very tiny vessels that color flow will not be able to detect. A color perfusion display can be seen in an organ, for example, here the placenta. In other cases in gynecology, for example, you can look at an ovarian tumor, and so on. Power Doppler can be named as energy Doppler, amplitude Doppler, Doppler angiography, and usually it is high sensitive or highly sensitive more than color, but as you can see, usually it uses one color, so it's very difficult to detect the direction of flow in comparison to color flow mapping. We'll discuss now how to measure, for example, the umbilical artery flow Doppler and what's the value of this. Usually, the umbilical arteries end in a low resistance vessels, which is the placenta, and this will lead to the presence of a high systolic flow and also a high diastolic flow. With advancing pregnancy, with advancing gestation, the placenta gets bigger and the vessels there gets less resistance. So the diastolic flow in relation to the systolic flow increases with pregnancy. And from this, we will have the so-called that the baby with advancing gestation will have a lower resistance, will have a lower indices. When the fetus suffers from oxygen diminution, like for example in cases of placental insufficiency, usually what happens is the so-called reflex redistribution of the cardiac output. Reflex redistribution of the cardiac output is where you will find that the vessels of the more important organ gets vasodilated on the expense of the less important organs. For example, the fetal brain is very important, so the vessels of the brain will have vasodilatation, whereas, for example, the fetal kidneys is not as important, so there will be vasoconstriction of the renal arteries. In the umbilical artery, there is relatively high forward velocity during diastole, consistent with blood flow into a low resistance vascular bed in the placenta, and this increases with pregnancy. This increase in dilatation that will lead to decrease in resistance, increases with advancing gestation. This change in the pulse velocity waveform can be quantified or measured in the way that we measure the systole to the diastole. This can be measured in a ratio between the systole and diastole, or can be measured in a ratio between systole over systole minus diastole, or can be measured in a ratio between systole and the total area under the curve between the or through the whole cardiac cycle. This is the so-called SD ratio, resistance index RI, or pulsatility index PI. This indices is usually decreases with gestational age, with advancing gestational age. If there is placental insufficiency due to placental disease, then the opposite happens. With advancing pregnancy, this pathology in the placenta will lead to more resistance to flow, and hence will lead to decreased diastolic flow in relation to the systole. Then the ratios between the systolic and the diastolic flow will increase. This will continue to happen till we reach a time where blood can pass only during systole, and the resistance in the vessels are too high that during the diastolic phase of the cardiac cycle, no blood passes forward within the umbilical artery, and this will lead to the so-called absent end diastolic flow. More severe cases will have more resistance, and this will lead to more spasm in the vessels, even during diastole. So blood will pass only during systole, but during diastole, it will not only be absent, but will be reversed. Blood will go the other way around, so you will have a positive systole and a systole on the opposite side. In cases where there is absent end diastolic flow and reversed diastolic flow, of course, there is no indices. You cannot measure systolic over diastolic or systolic over systolic minus diastolic, because once you have a zero diastolic flow or a reversed negative diastolic flow, ratios are not applied anymore or not applicable anymore. You can use the ratios as long as there is diastolic flow. Once absent or reversed, no more use of ratios. As you can see, for example, the systolic over diastolic ratio with advancing gestation, usually at 24 weeks, the mean will be 3.5. At full term, the mean will be 2.2. So the ratios decrease with advancing gestation. Same applies to the PI. As they can see here, the PI at 22 weeks is around 1.2 and decreases gradually to reach around 1 at 36 to 37 weeks. So again, the PI decreases with advancing pregnancy. Diminished flow, particularly in the diastolic phase of the pulse cycle, is associated with compromise in the fetus. Various ratio, as I said, vessels commonly interrogated will include the umbilical artery, aorta, middle cerebral artery, and the uterine arcuate or uterine arteries. Due to the redistribution of the cardiac output, you will find that there will be increased resistance in the descending aorta, in the renal artery, in the femoral artery, in the peripheral pulmonary artery, in the mesenteric artery, because all these organs are not essential to the fetus, so it will have more resistance to spare the more important organ, the cerebral artery, the adrenal artery, the splenic artery, and the coronary artery will all have decreased resistance in a trial to preserve oxygen and blood flow to these important organs. The next vessel we study is the middle cerebral artery, and the middle cerebral artery is important because normally in pregnancy with advancing gestation, there is increased resistance, the opposite of the umbilical artery. So you'll have a very small diastolic flow in comparison to the systole. If we have the fetus that is hypoxic, then the cerebral artery starts to dilate to redistribute the cardiac output more to the fetal brain, which is very essential. To do that, the ratio will be now decreased. It was normally high, and then it is decreased. This is very important. The so-called umbilical artery over middle cerebral artery, or the other name which is more recently used, the cerebroplacental index. This ratio, cerebroplacental ratio, is a ratio between the pulsatility index in the umbilical artery and the middle cerebral artery. Normally, the pulsatility index or the resistance index in the umbilical artery is decreased with advancing gestation, whereas the RI and the PI of the middle cerebral artery are usually increased with advancing gestation. If there is placental insufficiency, the reverse will happen. With advancing gestation, the umbilical artery will have increased resistance due to diminished blood flow in the diastolic period, and the middle cerebral artery will have decreased resistance because there is dilatation and more or less increased diastolic flow in relation to the systole. If you compare the ratio between the pulsatility index of the middle cerebral and the pulsatility index of the placenta, this is called cerebroplacental ratio. This ratio normally with pregnancy, the resistance or the PI here decreases and the PI here increases. So the ratio usually is 0.5, 0.4, 0.6. Once there is increase in this PI in the umbilical and decrease PI in the middle cerebral, the ratio will start to increase till it reaches 1. Once you reach a ratio of 1 between the pulsatility index of the middle cerebral and the placental or the umbilical artery, then this means that this fetus is already severely compromised and that the redistribution has attained a maximum value. So this fetus is at risk of placental insufficiency that may lead to cerebral hypoxia. And once there is cerebral fetal hypoxia, there is fetal brain damage. And this might lead to, of course, intrauterine either death or intrauterine cerebral injury. So the umbilical artery, middle cerebral artery, or middle cerebral artery, umbilical artery, whatever you use, ratio is important in these cases. There is no evidence that the use of other peripheral arterial fetal vessels, such as renal arteries, splenic artery, peripheral pulmonary arteries, provide any advantage in the identification of intrauterine growth restriction. If you have an intrauterine growth restricted fetus, what should you do? The most important thing is that you look into first diagnosis and then do Doppler. You confirm that there is IRGR. Of course, this is another lecture, but we will, the definition of IRGR is the fetal growth at below the 10th percentile for estimated gestational age. So, for example, in the case that we're going to do the live demo, I'll measure the fetal biometric measurements, and then we'll estimate the fetal weight and see if it is appropriate for age or not. If it is below the 10th percentile, then this is IRGR. Once you have IRGR, you do umbilical artery Doppler. If the umbilical artery Doppler is normal, then this is not a true fetal gross restriction. This is the so-called small for-date fetus. And small for-date fetuses can be followed up till term and delivered at term. It's better not to allow them to go into past date, but usually they can be delivered at 39 to 40 weeks. If you have an abnormal umbilical artery Doppler on the other way, you just follow up these cases. If you have a reversed end diastolic flow at any time after 32 weeks, then you deliver. If you have an absent end diastolic flow at 34 weeks, then you deliver. If you have an absent end diastolic flow before 33 weeks, then you try to wait 1 or 2 or 3 days more and give corticosteroids till the either baby or the mother has taken the corticosteroids for improving the maturity, or if there is reversed end diastolic flow, or if the biophysical profile is less than 6. So this is just a scheme of management. There are many, many other schemes, but it uses the Doppler in clinical management. And this is one of the most important things in medicine, is that you use a tool, here in this case ultrasound, in decision making. So you decide if the patient needs delivery or not based on Doppler. The third vessel that we are going to talk about is the uterine artery. Uterine artery usually is an artery with some resistance, especially in the early diastolic period. So in non-pregnant women, you will find that there is a systole, and then at the end of the systole, there is diminished flow in the diastole, and then with more increased flow during the diastolic period, and then at the end diastolic phase, there is positive flow also. This decrease after the systole is called the early diastolic notch. Usually the ratio between the systole and diastole are relatively high in non-pregnant women. Once the patient is pregnant, the placenta forms, usually starting from 8 weeks pregnancy, then gradually there is more blood vessels formed inside the chorion, inside the uterus, and this leads to less resistance from blood coming from the uterine artery supplying the placenta in this case. With advancing gestation, the diastolic flow increases in the uterine artery and the early diastolic notch disappears, usually this by 16 to 18 weeks. So once you find a woman pregnant at 18 weeks that has the same Doppler pulse wave form of the non-pregnant woman, this means the so-called placentation was not correct. So the formation of the placenta was not normal. This change, or this no change, the absence of the normal changes, may be a good predictor that this baby or this patient is liable to preeclampsia/intrauterine growth restriction. So screening of pregnant women somewhere around 12 to 14 weeks with uterine artery Doppler may be a good predictor for screening of the pregnant woman if she is more liable to get preeclampsia later in pregnancy, and screening the fetus if it is more liable to get IGR. If you have the normal Doppler changes in the uterine artery, this will have a much less incidence of those two complications. Once you find that there is no change or absence of change in the uterine artery, many advise now that these pregnant women should start taking aspirin before 16 weeks till 36 weeks. Of course, one of the other uses of color flow is to detect the site of the umbilical cord. In this case, or in this slide, you can see that there is sometimes called the nuchal cord or the nuchal loop of cord. This, of course, can be detected very easily with color flow mapping. You put the color on the area of the neck to see if there is 1, 2, or 3 cord loops. Of course, one cord loop around the neck is very normal. The only serious thing about nuchal cord, if you have 3 or 4 multiple cord loops, then this may cause complication like intrauterine fetal death or fetal distress during labor. But one cord loop is present in almost 30-40% of all pregnant women and of no significance. Of course, it's very difficult to talk about IGR in the same lecture. I'll skip the slides of IGR and I will go directly to how to use the Doppler in cases of IGR, because this is the most important thing. If you have an IGR detected, you will do a weekly umbilical artery Doppler. If you find a reassuring umbilical artery Doppler, you will deliver at 38 to 39 weeks. If you find abnormal artery Doppler, you will see if it is either decreased diastolic flow, but there is still diastolic flow, or absent end diastolic flow, or reverse end diastolic flow. If you have a decreased diastolic flow, then you will increase the frequency of testing, usually every 2 or 3 days. And as long as it is positive diastolic flow, but the ratio is decreased, you will wait at 30 till 37 weeks and deliver. If you find absent diastolic flow at 34 weeks or more, you will give corticosteroids and deliver. If you will find a reverse diastolic flow at 32 weeks or more, you will give corticosteroids and deliver. Finally, if you have a patient 30 weeks or 31 weeks or less with reverse end diastolic flow, then this is a dilemma, because if you deliver a baby at 28 weeks with IGR, then the baby will suffer from severe prematurity and severe intrauterine restriction, and this might have long-term consequences on the fetus if it survives. Meanwhile, if you leave such a fetus with reverse diastolic flow intrauterine, this fetus is liable to intrauterine fetal death or cerebral or brain injury. So cases that are severe IGR with reversed flow before 30 weeks should be individualized. You should discuss with the patient and then take your own or decision at the end. Other uses of color flow, of course, each of them is a separate lecture, but I'll just give you a hint of what are the other uses of color flow in Doppler, color flow Doppler in obstetrics. You can use it in evaluation of the fetal heart. As I said, fetal echocardiography has a lot to do with or use of color flow and Doppler. You can diagnose tricuspid atresia, tricuspid dysplasia, Epstein anomaly, pulmonary atresia, intact ventricular septum, pulmonary stenosis, aortic stenosis, hypoplastic left heart syndrome, VSD, AVSD, tetralogy of Fallot, double outlet right ventricle, complete transposition of the great heart. This is all a list of congenital heart disease that you may need color flow and Doppler to diagnose. Other fetal abnormalities that you can use color Doppler in to diagnose or to confirm are, of course, placental and umbilical vessels abnormality, like placental previa, vasa previa, subcentriate lobe of the placenta, single umbilical artery, true cord knots, placenta accreta, percreta, and so on. Renal vessels, of course, fetal renal vessels, as I said, very important to get by color flow. Intracranial vessels, if you have, for example, an aneurysm inside the brain, color will help you a lot. Intrathoracic vessels, again, if you have a chest tumor, for example, and you want to look at the blood supply of this mass. Intra-abdominal vessels, fetal and placental tumors like chorioangioma, for example, color flow and Doppler has a lot to do with the diagnosis. Other uses of color Doppler in high-risk pregnancy will be in red cell isoimmunization, diabetes mellitus, premature rupture membrane, maternal autoimmune disease, post-term pregnancy, twin gestation, evaluation of fetal heart, and diagnosis of fetal anomaly, as we said. In conclusion, the main focus, of course, of this lecture was on placental, umbilical, and uterine artery Doppler, but of course, you can use color flow in many, many things in obstetrics, and each of them will have more or less like another presentation, but the conclusion of this presentation or the take-home message is that, number one, don't be afraid to use Doppler. Doppler is very easy. Actually, everything is automated. You put the box on the vessel, you press color, you will have the vessel, you put the more or less pulse wave cursors on the vessel, you just adjust the size of the box and the angle, and then you press auto measurement, you will get the flow measurement. What you need to do is to understand the value of doing this Doppler. When to do it? And if you have a result back to you, an SD or an RI or a PI or a value, you know what this value means. Doppler will help you a lot in decision making in obstetrics, especially in cases of IGR and placental insufficiency, where actually monitoring of these cases are based primarily on Doppler ultrasound. Many obstetricians think that they don't need to know a lot about Doppler because they have a fetal medicine specialist or an ultrasonographer who will do the scan. But actually, even if you don't do it yourself, to understand what to do and when, you need to study it, because you will send an ultrasound, a patient for ultrasound, you will get a report back saying PI is 1.2 and the patient is 32 weeks. So is this normal? Is this abnormal? It is normal. Then you send the patient for another Doppler evaluation because you think the baby is IGR. The results come back to you with presence of IGR and a PI of 0.8. What does this mean? What should I do? Should I increase frequency of monitoring? Should I wait? Should I give corticosteroids? Should I deliver? So to understand all of this, it's very essential to all obstetricians and of course to those who are interested in ultrasound and fetal medicine. Thank you very much. I hope we can see you soon in another lecture or another presentation. I'm looking forward to hear from you and to know if there are questions and to answer them after the end of the live demo. I'd like to thank Mindray, of course, on hosting this webinar, and it has been my pleasure to be with you. Thank you very much. we will do now the demonstration of how to get the Doppler measurement in a pregnant patient. This lady is pregnant around 30 weeks. Of course, before we do Doppler, we have to do the standard scan. And the standard scan is that we look for the whole pregnant uterus. Doing that, we will see the presentation, it is a cephalic, the position, the back is to the left side, and the lie, of course, is longitudinal. In the meantime, we will get an idea about the location of the placenta. It is fundal with a slightly posterior extension. Also, we can have a subjective estimation of amniotic fluid. We can see that the amniotic fluid is adequate. And then we will go from that to the obstetric measurement. This machine, the Resona 6, has the so-called automatic obstetric measurement. So we get the plane of the biparietal diameter, and we choose to do biparietal diameter, and automatically the measurement is there. Also, the occipitofrontal diameter, you don't need to trace anything, just get the proper plane. The same applies to the abdominal circumference. If you get the proper plane of the abdominal circumference, the measurement also can be automatically detected. And here you just need a very slight modification to move the cursor, and then you press set, and here is the abdominal circumference. The same also goes with the femur lens. You just get the plane of the femur lens, and you choose auto, and here it is. So the whole measurements are there. The estimated age from ultrasound is 31 weeks. The estimated age from the last menstrual period is 30 weeks, 5 days. The estimated weight here is 1.862 grams, which is adequate or appropriate for gestational age. If you want to do Doppler, the first and the most important thing is to get the umbilical Doppler. You get a section of the umbilical cord, and as you can see here, this is a good loop where more or less there is no lot of movement. You can see that there is no artery, there is 2 arteries and 1 vein, and then you can put color and you put pulsed Doppler, and you get the measurement. After you get the proper plane and the proper measurement, you can measure the indices. First, after we get the umbilical artery, we try to of the quarter segment. Usually we do it in 2 segments, sometimes 3, especially if there is an abnormality, to confirm that the changes we find is present in more than 1 segment of the cord. After we get a good wave, then we do measurement, and also you can do umbilical measurement, as you can see here, all the trace of all waves that you have done, and from it, the RI is 0.56, the PI is 0.81, and the S/D is 2.2. All these measurements are normal for 30 weeks. The other Doppler that you should look for in cases of IUGR or placental insufficiency is the middle cerebral. And the middle cerebral is you get the plane of the biparietal diameter, and you get a little bit low towards the neck, where you will find the base of the skull and the so-called circle of Willis. Once you get the circle of Willis, you identify the middle cerebral artery, usually the one that is going laterally like this one, and then you do the trace. Usually, of course, the diastolic flow is low, and hence the indices are high. This is normal in middle cerebral artery in cases with normal placental insufficiency. If you have a normal umbilical flow, you don't need to detect the middle cerebral or see the ratio between the two. If you have a low high resistance in the umbilical artery, then you should look, of course, for the ratio between the umbilical artery Doppler and the middle cerebral artery Doppler. Okay, this is the middle cerebral. The third thing you should look for, of course, not in these cases, usually in a little bit earlier pregnancy, is the uterine artery. The uterine artery Doppler, get to the cervix, and you go a little bit laterally, you will find the iliac vein and the iliac artery, and you'll find the uterine artery crossing, as you can see here. This is the uterine artery, and you can get the waveform, you can see usually the diastolic flow is very high, and if you measure the indices, you will find that the resistance is very, very low. As you can see here, the RI is 0.36, the PI is 0.52. So this is a case of a single living fetus, cephalic presentation, longitudinal lie, left occipital transverse position, with an estimated gestational age of about 31 weeks and an estimated weight of 1.8 kilograms, with adequate amniotic fluid, with normal fundal placenta, and all the Doppler indices are normal in the umbilical, middle cerebral, and uterine arteries. Of course, in this case, you don't need to look for the ductus venosus, but I'll try to show you how to get it. It's a little bit difficult, but you can get it in the longitudinal plane and in the transverse plane. In the longitudinal plane, you will find a very short ductus venosus, you can see here, usually characterized by a turbulent flow. And as you can see here, it is characterized by A wave, C wave, and so on. And if you find A wave is reversed or absent, then there is abnormality. Again, this is how to get the ductus venosus. This is the ductus venosus, okay? And this is the flow in the ductus venosus. Give me نفسك ثانية. Okay, so this is usually the Doppler changes that you need to look. Also, you may use Doppler or color flow to detect other things like renal arteries. For example, you want to see that the renal artery is present, and of course, this will mark the presence of the kidney itself. Here you can see the aorta, and this is the right renal artery. If you would go to the other side, you will find the left renal artery, and here it is. This is the left renal artery. If you go a little bit below, at the level of the bladder, you will find the iliacs surrounding the renal bladder. And from this plane, you can confirm that there is two umbilical arteries, okay? In a single umbilical artery, you will find one of these arteries is absent. You can see here both umbilical arteries present, right and left of the urinary bladder. Of course, there's a lot of uses of color in echo, but this is for another lecture, inshallah. Thank you.
Hello, everyone. I'm Mohamed Momtaz. I hope you have enjoyed the lecture. I have a few questions. I will start looking into them, and then try to answer all of them. The first question is concerning nuchal cord, and is to clarify for those doctors who are not well trained and having false fixed beliefs that it causes intrauterine fetal death, and once seen it necessitates cesarean section. As I told you in the presentation, the presence of nuchal cord is a normal finding and does not necessitate any kind of intervention. My advice is, even if you find a loop of cord around the neck, is not to tell the patient. You just put it in your note so that you can follow up the patient, but not for increasing the worries of the woman or the mother by telling her that there is a nuchal cord. Also, if you're writing a report, if you write it, you must mention that it is a normal finding. Actually, 30 to 40% of all fetuses might have a nuchal cord at one time in late pregnancy. So it is not an indication to worry. It's not an indication to intervene. It's not an indication to C-section. Sometimes there are many loops of cord around the neck. This is a very, very rare instance where you find 3 or 4 or 5 loops of cord around the neck. And this may cause to the obstruction of the blood flow inside the umbilical vessels. But this is extremely rare. You can see it only once or twice in your career, and it may cause intrauterine death, but this is not a thing that you look for in every case. So if you look for a nuchal cord and you find it, then it is a normal finding. The second question is, what is the strength of using only uterine artery to diagnose preeclampsia if your LA cannot conduct PGF or placenta growth factor? Actually, it's very important to differentiate between diagnosis and screening. Uterine artery Doppler, placenta growth factor, or any other lab test is not diagnostic of preeclampsia. Preeclampsia is diagnosed on clinical grounds. It's not diagnosed by any laboratory tests. They are tests to screen or to predict women who may have an increased incidence of preeclampsia. Uterine artery alone has about 70 to 80% sensitivity to detect or to screen for women who have high risk for preeclampsia. And if you add the laboratory test, the placental growth factor, and other factors, you may increase this sensitivity to 90 or 95%. If you don't have a lab, I would advise that can do these tests, or it is expensive or it's not available, I would advise to do uterine artery Doppler screening at the end of the first trimester or early in the second trimester. This will help you to select women who are more prone to preeclampsia. And also, it's very important that now we can have, or we can give them some kind of treatment, prophylactic treatment, aspirin, in a dose of 100 milligram or more, given to women who have susceptibility to get preeclampsia at starting before 16 weeks and continue till 35, 36 weeks. It has to be 100 milligram or more, better 150 in some research work, and this should be given daily as prophylaxis in women who have high risk. There is software that is available in the Fetal Medicine Foundation where you can put the basic data, and this will help you to have a risk assessment. Also, you can do the uterine artery Doppler and add to that. And if you have the laboratory tests, you can add that also to it. The next question is for multiple pregnancy. What's the role of color Doppler? Of course, in multiple pregnancy, the role of color Doppler is assessment of each fetus exactly in the same way. Also in screening for preeclampsia and IUGR, uterine artery Doppler. And to add to this, in cases of monochorionic twins, there is a role for color Doppler because monochorionic twins have a peculiar situation where there is one placenta and there is vessel communicating between the two fetuses. This communication between the two will lead to certain specific complications of monochorionic twins, like the twin transfusion syndrome, like anemia polycythemia sequence syndrome, like TRAP, twin reverse arterial perfusion syndrome. And these complications, the use of color Doppler will add a lot because they help in the diagnosis of the condition and in the management, in the staging, for example, of twin transfusion syndrome. Also, in cases of monochorionic twins, the condition or the situation called selective intrauterine growth restriction, where one fetus is or have intrauterine growth restriction and the other one does not, may cause specific problem, because if the intrauterine growth restricted fetus dies within the uterus before delivery, the other fetus might suffer from sudden hypotension or anemia or even intrauterine fetal death. So color Doppler in the cases of twins can be used for each fetus alone, as in cases of singleton, and also in cases of monochorionic twins, it has a role or a value. Another question is that how can I relate between Doppler indices and placental thickness, please? Actually, placental thickness is or have a wide normal range. So to say that this is a thin placenta or a thick placenta is difficult to diagnose. Thick placentas usually are associated with the so-called placental edema, and it can occur in hydrops fetalis and viral infections, sometimes in diabetes mellitus, but it's not or cannot correlate with Doppler indices, whether of the uterine artery or with the fetal umbilical or metacerebral. On the other hand, IUGR fetuses sometimes are associated with small, thin placentas, and if the baby is intrauterine growth restriction due to placental insufficiency, this, of course, might be associated with Doppler indices, that normal Doppler indices that we have talking about in the lecture. But to correlate a certain thickness of the placenta with Doppler indices, I don't recommend doing this. Very, very thin placentas may be in cases, or may be seen in cases, for example, of polyhydramnios, like, for example, 20-20 transfusion syndrome. You will hide a very, very thin placenta. But this is not because the placenta itself is thin. It is because the placenta is overstretched over a large surface of the uterus, and due to polyhydramnios, the placenta would look thin. But if you, for example, do amnio drainage, or if the liquid returns to normal after fetoscopic laser ablation, then you will find that the placenta starts to get back to the normal thickness. The next question is, what is the cutoff value for abnormal cerebral placenta ratio? The cutoff value is 1. Normally, the umbilical artery pulsatility index is low in comparison to the middle cerebral artery pulsatility index. With advancing placental insufficiency and intrauterine restriction, the brain will have vasodilation of the vessels, whereas there is spasm in the umbilical artery vessels in the placenta. So you will find that the resistance inhibition pulsatility index in the brain gets lower, and in the placenta gets higher. Once the PI in both vessels are equal or reaches 1, the ratio between the two indices, then this is the measurement, then we have to intervene, because this is the translation of the condition that baby has done the best to redistribute the cardiac output, and the reserve after that is very low. So if this fetus is near maturity, it's better to be delivered. Another question. Notch in the uterine artery accepted till the 22 weeks. I didn't say so. It's not accepted till 22 weeks. It is accepted till 15, 16 weeks. The question is, as read previously, I don't know where you read that, but the notch should disappear early in the second trimester. So if you find the notch at 20 weeks, not even 22, this is abnormal. The problem, if you wait till the mid-trimester or second trimester anatomy scan, 20 to 22 weeks, and do the uterine artery Doppler, is that if you find a persistent notch at that time, to intervene by giving aspirin is very late. All the studies have shown that starting aspirin at 20 to 22 weeks will not affect the prognosis of these cases. So you need to give the aspirin earlier. You need to give the aspirin before 16 weeks. So if you're going to give it based on the persistence of the notch, then this should be done at about 16 weeks. If you're going to give it based on the ratio, the pulsatility and resistant index of the uterine artery, with or without other blood tests, then you can do that starting from 12 weeks. Is there a role of Doppler in detecting gestational age? No, there is no role for Doppler in detecting gestational age. Detecting gestational age is by accurate estimation in the first trimester. This is very, very, very important. If all the things you can do in the first trimester is to get a crown rumplance of the fetus to do the so-called dating scan and record this is the base of the gestational age estimation. You can do that later early in the first trimester, 15, 16 weeks, using the biparietal diameter, but it's not as accurate. Once the patient is late into the second trimester or the third trimester, there is no ultrasound that can detect gestational age. Ultrasound will detect the size of the fetus, the fetal growth, in relation to the estimated gestational age based on either a very short last menstrual period or an estimated date of ovulation, like, for example, in cases of induction ovulation, or an estimated date of embryo transfer, like an IVF, or an ultrasound scan in the first trimester, where this is the base for follow-up of these patients. Another question, is there a role of Doppler in early first trimester in cases of repeated missed abortion? No, there is no role in the first trimester of Doppler, because uterine artery normally is or changes late in the first trimester after the placenta forms. So actually measuring uterine artery Doppler before 8 weeks is expected to show that there is a diastolic notch, there is relatively diminished diastolic flow in cases where this pregnancy will end in early abortion or not. So there is no value of doing Doppler of the uterine artery in cases of repeated missed abortion, or blighted ovum, or anembryonic pregnancies. Of course, there is a role if you have a repeated abortion late in the second trimester due to intrauterine fetal death, because sometimes this is associated with placental insufficiency. This is a different story. Is there a role for Doppler early in first trimester? We said that. What are the Doppler parameters upon which intervention should be attempted in cases of 20/20 transfusion? 20/20 transfusion is classified into stages, and these stages, the first stage where you will have a more or less polyhydramnios, oligohydramnios sequence, and of course a normal growth and diminished growth in one of the fetus. Stage 2, where you will have an absent urinary bladder in the so-called donor fetus, and then stage 3, where you will have an abnormal Doppler in one or both fetuses, where you will have umbilical artery Doppler changes. Actually, nowadays, we suggest management of 20/20 transfusion early, actually even stage 1. Sometimes it is recommended to intervene by doing fetoscopic laser ablation. The recommendation is starting from stage 2, of course, but even if the case cannot come for follow-up or the patient is referred from another city, because of course centers who do fetoscopic laser ablation are only one in each country or one in each state or one in each city. So it is recommended now in some centers that even at stage 2, you can start by doing it. What about the decidual flow? The decidual flow, if it is normal or not, my advice is not to look for it, because of course, as a predictor, I don't think it's important to say that this is more or less a healthy pregnancy or not. But of course, in cases of blighted ovum or anembryonic pregnancy or missed abortion, the decidual flow will be minimal, will be much less than the normal, and this will confirm the diagnosis. I don't think there are other questions. So There is. Please put your question online. I see a raised hand, but I cannot see the question. Okay, there is 2 questions more. Evaluation of fetal weight with respect to Doppler indices and placental thickness to detect gross curve. Fetal weight is the way to diagnose intrauterine gross restriction. The gross curve, the potential growth curve for the fetus itself, is put by serially measuring the fetal weight and putting it against the gestational age. Placental thickness and Doppler indices has no value in this condition. If you're going to follow up the fetus against its own curve, so you have to measure its weight serially every 2 weeks, 3 weeks, 4 weeks, and put it on a curve. This fetus, after 2 or 3 measurements, will show a certain curve that it should follow in relation to other standards. So if the fetus is following its own growth curve, then it's doing well. If the fetus is not, then the baby or the fetus may be considered growth restricted, although that this fetus, in comparison to the standard of the population, maybe not. This is a different way to diagnose fetal growth restriction, but it needs that every patient followed up every 3 to 4 weeks, starting from early second trimester, and measuring the weight and putting it on a curve so that this fetus have its own weight curve. This is difficult in many, many countries. The patient cannot do that. The insurance cannot pay for that, and the government still does not support that. Significance of reversed aortic isthmus flow in fetal growth restriction. This is a good question, actually. And reversed aortic isthmus flow is a measurement of fetal hypoxia that is correlates with the severity of fetal growth restriction. I wouldn't do it. I don't think it is of value. It is theoretically or present in many papers, but I don't think it is of value. Actually, the reverse diastolic flow, if present, is an indication of delivery, even at 30 or 31 weeks. The condition of using other parameters other than the umbilical artery in detecting the fetal well-being to decide to deliver it, other than the umbilical artery flow, is the venous flow, and I would recommend doing the ductal stenosis, but only when there is a decision that has to be taken before 32 weeks for delivery. So that if you have a baby at 34 weeks or 35 weeks with abnormal umbilical artery Doppler, then you don't need to look for venous Doppler. Actually, you deliver these babies. The baby is too small to be delivered, then you need some reassurance if this baby can survive for a few more days or not, then looking for venous Doppler or ductal venosus is okay. Doppler has any harm in the first trimester? Yes, this is a very good question. If you're going to use Doppler on the fetus itself, then you have to use certain parameters. I advise you to go into the International Society of Ultrasound in Obstetrics and Gynecology. They have the settings for the machine for the first trimester. You should use the minimum power, and you should limit your use in Doppler. Actually, many doctors just put the pulse Doppler on the fetal heart to see its heart for a long time. This is not advised. Also, the color Doppler in the first trimester has certain limitation. So the use of Doppler in general is limited in the first trimester to certain powers. I would advise to go to the website of the International Society of Ultrasound and Gynecology. You will find the settings. You put your machine and save it as first trimester Doppler. If you have to use it in the first trimester, then you should do it. How do you explain abnormal umbilical artery Doppler without fetal smallness? This is also a very good question. Sometimes there is an abnormal umbilical artery Doppler and the fetus is borderline, is not yet cross-restricted. Actually, this can be explained by the answer to the question about having the fetus own curve. Sometimes if you put the fetal weight against the normal growth curve, you will find that it's not below the 10th percentile, and still you find a high ratio of the umbilical artery Doppler. This sometimes is caused by that this fetus is small in comparison to its own growth curve. So if you follow up these fetuses 1 or 2 weeks later, you will find that the baby is not growing well, although the weight is not yet below the 10th percentile. And this sometimes needs intervention or delivery if you'll find a relatively not very small fetus, but abnormal Doppler and near maturity. This might be an indication for delivery. How to differentiate IGR from small for gestational age? Doppler, very simple. Small for gestational age is a small baby with normal Doppler findings in the uterine artery and in the umbilical artery and in the cerebral artery, and also with a normal well-being, with a normal fetal biophysical profile, and usually with normal amniotic fluid. This is a small for gestational age. IGR is a small baby that has abnormal placental function and consequently will have abnormal Doppler in the umbilical artery, usually associated with changes in the middle cerebral and in the uterine artery also. When reading a fetal weight percentile chart, do you use the ultrasound estimated gestational age or last menstrual gestational age for small gestational age? Very, very good question. Again, you use the last menstrual period gestational age if you have an accurate last menstrual period. Estimated gestational age from the ultrasound itself that you're doing, of course, is of no value, because the estimated gestational age from a small baby will be small, will be less than the patient. So you have to have either an accurate last menstrual period or estimated gestational age from ultrasound that was done in the first trimester, not the ultrasound that you're doing, or even the ultrasound that you have done late in the second trimester or early in the third trimester. So the patient has to have an ultrasound dating of pregnancy in the first trimester using the crown rump lens. A measurement of uterine Doppler in management of recurrent pregnancy loss. I don't advise doing that. Actually, this is not theoretical, as you, proven. It's just a theory that maybe uterine vasculature is not well and implantation is not well, but I doubt that this is of value. Is there any effect on the diastolic curves? I don't understand the question. Doppler in cancer detecting, of course, this is another lecture. Cancer detection in the field of gynecology is, of course, cancer cervix, cancer body, cancer tube, cancer ovary, and there is a big role of caloric flow mapping and Doppler in diagnosis of cancer, especially tumors of the ovary, sometimes also tumors of the uterus, but of course it is a separate lecture, so we'll not have enough time. I'd like to thank you all very much. I think we have covered about 20 questions, and thank you very much. I'd like very much to thank Mindray International and Mindray Egypt for inviting me to give this lecture, and it was my pleasure to be with you from all over Africa. Greetings from Cairo, and lovely to be with you, and I hope to see you soon. Thank you very much.